many of you probably know, and also Dr. Cindy Geppert from the VA, who originally many years ago did some version of this talk. They really put this together, so they are the real creators of this talk. And over the years, through many echoes and many other things, it's kind of continued to get modified, and this is where it stands now. So although my name is listed here, full credit to Drs. Geppert and Duhigg for working on this initially and creating this talk. So I will start with that much needed acknowledgement. So we're gonna go quickly about, because we've covered this a lot. So this related concepts of addiction or substance use disorder, right? Pseudo addiction. We're gonna talk about sort of risk factors. Really, the heart of this talk is, can we prescribe opioids in a responsible manner? And if so, what are the components of it, right? So that's really what we're gonna fall into, right? So that's sort of the initial question to start with. What are the components of responsible opioid prescribing? Can it be done? And I think if it is to be done, these are the components of it, and we're gonna address each of these over the next 30 minutes or so. I think first, in order to be able to prescribe opioids responsibly, and remember right now we're talking about patients with chronic pain, we must be familiar with individual risk factors for opioid abuse. What are the risk factors that a person brings with them? We must use risk assessment tools that are validated. And finally, even once the opioids are prescribed, I think we need to do our due diligence and continue to provide ongoing monitoring for aberrant behaviors. And I think we must do all three of these to really be able to prescribe opioids in a responsible manner. And that being said, I think also important to point out that per the CDC guidelines from 2016 and most recent revision update to them, which just happened, fairly recently, opioids should not be first line, right? So as we begin this talk, it's important to keep in mind that these patients, we've already tried other things, right? That we often talk about, such as our non-opioid pharmacotherapy. We've already tried our non-pharmacotherapeutic interventions. And after trying all those things, we maybe come to a point where we're thinking, this is a patient who may benefit from careful prescribing of opioid pain medications. So how do we proceed? So that's where this talk starts, and let's pick up. First of all, I start with the definition of addiction as defined by the American Society of Addiction Medicine. And American Society of Addiction Medicine, or ASAP, says that addiction is a primary chronic disease of brain reward, motivation, memory, and related circuitry. In fact, we have decades worth of neurobiological data showing that when a person develops a substance use disorder, it affects multiple parts of the brain, right? All of these circuitries that are listed here, to a point where the person comes to see that substance of addiction as being necessary for survival, right? It becomes a basic physiologic need. And when that happens, the manifestations are not just physical, they're also psychological, social, spiritual. And ultimately, the individual, just like this points out, pathologically pursues reward and or relief by substance use and other behaviors. Other things will be sacrificed to pursue, usually that relief. I mean, I hear this a lot, as I'm sure many of you do, from our patients, that I don't used to get high, I used to feel well, or I used to feel normal. How often do we hear this? Again, it's that neurobiological basis of substance use disorders, where the brain has changed enough, right? The circuits have changed enough to where a person is in a state of dysphoria or anxiety until and unless that's taken away by using the substance. So it winds up affecting everything. Now, another definition, so if that's just a one slide on definition of addiction. This is a definition of aberrant behavior as defined by SAMHSA. Aberrant behavior is a behavior that suggests prescription misuse, abuse, or addiction. So it's just that. It's this behavior that if we're prescribing opioids, we should be on the lookout for, because it might suggest that something deeper is at play, that the person may not entirely be benefiting from the prescribed medication. This is an old quote from Fishbane, which I think holds true even almost 2 decades later, right? Which is, prescribing opioids will lead to abuse or addiction in a small percentage of chronic pain patients, but a larger percentage will demonstrate aberrant drug-related behaviors, that's what that ADRBs is, and illicit drug use. These percentages appear to be much less if chronic pain patients are pre-selected for the absence of a current or past history of alcohol or illicit drug use or abuse addiction. So a lot, right? It's a mouthful. But I included this because we're going to break all of this down over the next several slides. I think this one quote really captures partly the essence of the first part of this talk. So now let's go into it in detail. So first it says, prescribing opioids will lead to abuse or addiction in a small percentage of chronic pain patients, but a larger percentage will demonstrate these aberrant behaviors and illicit drug use, right? That first statement. So what's the data behind it? So over the years, if you look at the data, people have always tried to estimate what percentage of the people who are prescribed opioids for pain will wind up developing dependence, right? To use DSM-4 terminology, opioid use disorder, to use DSM-5 terminology. And the data is all over the place, right? From, I think it's 2 to 80%, depending on which study you look at. So it's all over the place. So we got to look at some bigger reviews. So I think one of the really good meta-analysis was done by Kevin Voles here at UNM in 2015, looking at 38 studies. And what Kevin's group really showed is that about 10%, right, 8 to 12%, as they showed here, of people prescribed opioids for chronic pain will actually develop addiction, as defined in the DSM-4. But a higher percentage, 21 to up to 30%, will display some signs of problematic use, right? Similarly, in this other, if you look at CDC, in 2016, they say rates of opioid abuse or dependence diagnosis as per DSM-4 were actually, less than 1% if people were prescribed low daily dose of opioids and about 6% with higher dose, right? And this Minozzi study from 2013 also gave slightly low rates of addiction, opioid dependence, than the Voles study. But I think this is a pretty good estimate. About 10% will wind up developing addiction, up to 30% will display problematic behaviors, right, in this big study. And I think that's why it's really important for us to recognize these problematic behaviors, these aberrant behaviors, because if we see them, we better do something so that this progression to addiction, to sort of a full opioid use disorder does not happen, right? So aberrant behaviors, again, are about 20 to 30%, just a reference slide, not gonna go into too much detail here. I do wanna introduce this concept of complex persistent dependence, which was initially introduced in about 2018, as you can see here. And interestingly, this year there was a paper that came out that talked about complex persistent dependence to benzodiazepines. Makes sense, but now we're also starting to apply this term to sedative hypnotic misuse. But complex persistent dependence is just that. About 20% of primary care population who are long-term opioid treatment will start to kind of display concerning behaviors. These are patients who maybe have a lot of interference due to pain into daily life. They start displaying some aberrant behaviors. They start requiring higher and higher and higher doses of opioids. Often these patients have a lot of psychiatric comorbidity. So important for us to provide appropriate treatment, and the patients may be unwilling or unable to taper opioids, despite the fact that their functioning is continuing to deteriorate despite being on these high doses of opioids. And if you are too aggressive with a taper or just stop the opioids, behaviors suggestive of opioid use disorders very quickly emerge. So this isn't a graphic representation. This big triangle is everyone prescribed opioids, all the patients with chronic pain that are prescribed opioids, right? A majority do fine, right? A predictable regular use. And then about 20% start displaying complex persistent dependence, as it's shown here. And the tip of the triangle, this little group that develops really compulsive use and starts meeting criteria for opioid use disorder or addiction. So we really got to intervene in this stage, right here, before it becomes a full-blown opioid use disorder. That's really what I'm getting at. So we got to be mindful of and know what some of the risk factors for aberrant behavior are. By far, in study after study, the biggest predictor of aberrant behaviors to prescribed opioids is a lifetime history of a substance use disorder. And interestingly, that includes alcohol and even tobacco. But the biggest association, predictably, is between a history of opioid use disorder and aberrant behaviors to prescribed opioids. So we got to be very mindful of it. Psychiatric comorbidity, history of pre-adolescent sexual abuse, family history of substance abuse, history of legal problems, younger age, and increased functional impairment associated with pain are associated with someone misusing their prescribed opioids, right? And that's what this slide is really getting at. It's a study by Boscarino, from 2010, which actually showed that basically when you added a history of opioid use disorder, the odds ratio or the risk of someone misusing prescribed opioids was 56 times higher, right? So by far the biggest risk factor. So we got to keep that in mind. We got to know these are the risk factors, right? So remember, first part of opioid prescribing, know the individual risk factors. And this is what you're looking at with a special attention to the first one, that lifetime history of a substance use disorder. Next, if I'm going to prescribe opioids to a patient, I should use a risk assessment tool that has been validated. There are several of them there, but the one that I know the UNM Pain Consultation and Treatment Center uses and that we often recommend is the SOAP-R. It's a 24-item questionnaire. It's validated in primary care settings as well as pain management settings. And you can see that it's got a pretty high sensitivity, it means that it's going to pick up any history. But I want to draw your attention to this. The PPV stands for positive predictive value. The NPV stands for negative predictive value. What does that mean, right? So what it means is that negative predictive value means that if someone scores low on the SOAP-R, how likely are we that, how I guess accurately are we able to predict that the person will not misuse opioids? And the positive predictive value is that how likely are we to be able to predict that someone will misuse opioids, right? And that's really what we want to do with these screeners. So I think the most important numbers here, much more so than the sensitivity and specificity, are the PPV and the NPV. And you can see that the negative predictive value is very high at 87%. So in other words, if someone scores really low on the SOAP-R, we can feel reasonably comfortable that this is a person who's unlikely to misuse prescribed opioids. But look at that positive predictive value. It's just over 50%. It's basically a flip of the coin. So just because someone scores high on it does not mean that it's predestined that this person is going to misuse the prescribed opioids. What it means is that we should be vigilant, we should be careful, and follow this up with a very thorough assessment. Because remember, a full assessment is the gold standard. So that's the caveat with all of these screeners, that they have a much higher negative predictive value and a much lower positive predictive value. So important to keep that in mind, as we move forward. And there are also other ones. There is also something called the continuing opioid misuse measure, or the COM, which is used in people who are already prescribed opioids. So once the opioids are prescribed, the SOAP-R may be of relatively limited value compared to something like the COM, the continuing opioid misuse measure, right? And these are all available online, and we've included a couple of links where they can be found. So I already talked about this, the predictive value, right? Also, the CDC guidelines say that there is actually sparse evidence of these screening tools. So the key thing is, right, that we use them as part of the overall assessment, but we don't rely simply on the screening tools, because by themselves, they don't carry a whole lot of evidence. There are all these methodological problems as listed below. And also, I think one of the things that we often grapple with is what are the groups that were tested on, that were validated on. For example, right, it's very unlikely that American Indian Alaska Native populations, right, were part of some of these validation studies. In fact, I know they're not, right? So we got to know what generalizes, what does not. The key point I want to make, looking at the time here with the risk assessment tools, is that we don't use them to deprive patients of pain management. The idea is it allows us to risk stratify, right? And basically develop and come up with the most efficacious and safest treatment strategy. So we use them to stratify risk in a particular patient have that discussion in a patient-centered manner, and come up with a good treatment plan that might allow us to be safe in our treatment. And the next three are reference slides that are listed, right? So the SOAP-R actually comes with suggestions. What do you do? So this is if someone scores high on it, this is kind of a moderate score and low score. So those are there for reference. And of course, these slides will be distributed to the team. So now we've prescribed, we know the individual risk factors, we've done the SOAP-R, maybe our patient scored pretty high on the SOAP-R. So we had a patient-centered discussion saying, listen, I do want to be able to help you. I know you're in pain. We've tried all these other things. They have not helped. But I also know that based upon what we know, with someone who scored as high as you did, you might be at a higher risk for not using these opioids exactly how I prescribed or running into problems with it. So these are the safety measures we're going to put into place. Maybe we're going to see you more frequently, every couple of weeks. We're going to make sure that you're seeing Dr. Fernandez, for example, right? For psychotherapy to address your underlying post-traumatic stress disorder, right? We're going to have very close follow-up to make sure that we are able to treat your pain safely and effectively. So we start doing it. And the third part of responsible opioid prescribing, remember, is monitoring for aberrant behaviors. And there are many of them there. And we've broken them up into kind of mild or the green light ones, the moderate ones, which are kind of the more concerning aberrant behaviors. Generally, the moderate ones suggest developing compulsive use, right? Like significant energy spent assuring supply. Like I've got this one auntie who I know has some extras. I know there's this doctor in the other town who doesn't always check their PMP, right? So that's kind of multiple unsection dose escalations. They're running out of or losing their prescription on a recurrent basis. The decline in function is very important. If what we're doing is helpful, we should be seeing functioning improve. And if the functioning is declining, we need to talk about the patient. Maybe this treatment is not working, right? And then these are the red or the severe aberrant behaviors. And the most severe, I think, are these the ones in red ink, right? Such as diverting or selling the prescription, forging prescriptions, or injecting the oral medication, which of course can be so dangerous, right? So I've listed them for reference. Always what we need to be doing, this is the other take-home point, is balancing benefits and risks, right? Do the benefits of this treatment outweigh any side effects and risks of the harm to the patient or the society? What we as providers shouldn't be doing is asking questions like, is the patient good or bad, or do they deserve pain meds? It's really about balancing those risks and benefits. So we need to be having this discussion in a very open-ended, transparent way with our patient. Listen, I am worried about your safety because, and very objectively outlining the behaviors that we have seen. And there is some literature from pharmacy literature recently that supports that if we focus on safety and even use that phrase, I am concerned about your safety, patients might be more receptive to that conversation. But we need to be having that conversation, as this cartoon kind of demonstrates, right? It shows this person, right, who's sitting there, the patient, and the doctor's got all these regulatory guidelines everywhere and says, too many people are dying, the situation's out of control. I kind of thought they were helping you, but right now I have to have you stop your Lortab pills. And the patient's going, what did I do, right? So we gotta be more precise than that. We need to individualize the message we're giving, apply those risks and benefits to the patient with whom we're working, and ultimately make that decision. Because, right, if someone's stable and we just simply taper or aggressively or stop the medicine, there's some potential harms to the patient, including polypharmacy, including things like, invasive procedures, end of the care relationship. And some of the studies have shown higher incidence of illicit substance use and mental health emergencies, including suicidal ideations, when medications are tapered fairly aggressively. So we got to be mindful of it. We have to look at both sides, right, to make that decision. And again, think about balancing benefits and risks. Remember that clinical interview and judgment are still the gold standards. And we just have to be transparent. I think in terms of risk management, we start with the idea that the universal precautions, every patient is potentially at risk. However, patients might be at different risk levels, and that's what that personal history, those risk assessment tools allow us to help us with, to risk stratify. But once the opioids are prescribed, we really have to use some of these best practices in order to minimize risk, including opioid agreements, ongoing screening, ongoing assessment, monitoring urine toxicology, prescription monitoring programs. And for patients who are at high risk, we need to monitor them quite intensely and quite frequently, including things like pill counts, frequent visits with limited number of pills dispensed, right? Opioid agreements, just a note on that. We do a whole talk on it, so I'm not gonna go into too much detail, but it's really a tool of communication. Sets the expectation. What can the provider expect from the patient? What can the patient expect from the provider? There should be specific behaviors, specific goals, specific expectations, because I think that's really important. It sets the expectations right at the onset of treatment. Urine toxicology, I know Dr. Warwick talked about this last session, and he's an expert on it. But if we're prescribing opioids, we need to monitor toxicology, and we should know what the urine tests and what it does not test. And when in doubt, call up the lab, call up the reference lab, ask questions, and try to be accurate with it. Medicalize, don't stigmatize non-adherence. Manage this within a practitioner-patient relationship. We are not the sheriffs, right? We're not law enforcement, we're clinicians. We're working with a patient. And remember that our patients are often highly stigmatized. So we really want to be empathic. We really want to be non-judgmental, even if our initial instinct is, I don't believe it. Talk to your patient, listen to them, and again, be transparent. And if you're seeing aberrant behaviors, again, just a reference slide. To the left are some questions we may want to ask the patient, right? On the right are the questions we should be asking ourselves. And I think those are the really important ones. And that's where SAMHSA. Has the pain condition progressed? Is the patient using more pain meds because their pain condition has changed? Or is there a new pain generator? Is there an undiagnosed psychiatric disorder that needs treatment? Or have you set and followed limits and rules? And that limit and rule setting, remember, starts right at the beginning with that treatment agreement. In general, and we're going to end here in a minute or two, if we see mild to moderate aberrant behaviors, we're going to respond by increasing the number of visits. Again, tighten things, more intensity, more frequency of visits, get collateral information, make sure we're treating those underlying psychiatric illnesses and emotional pain that might be contributing to the overall picture, right? When do you taper opioids? Well, generally, if the moderate to severe aberrant behaviors continue, despite taking steps, right? Despite adding more structure, if that's continuing, then we really ought to be thinking about tapering opioids. And if possible, we want to do a humane long taper as we start those alternative pharmacological and non-pharmacological modalities. And that's a good way to make sure that we're not abandoning the patient, right? And this is a New York Times article. I like this quote saying that the decision to taper opioids should be based on whether the benefits for the pain and function outweigh the harms. And that takes a lot of clinical judgment. It's individualized and nuanced, and we can't codify it with an arbitrary threshold. There are going to be times, though, when you must stop the opioids. It's usually those things that I had listed in red ink: injecting oral medications, selling prescription, things that are just so dangerous that we need to act now. And, chances are that for these patients, if there is underlying opioid use disorder, we're going to think about switching them over to a treatment for opioid use disorder, such as buprenorphine. And if you're seeing this concerning behaviors, bring that case up to ECHO, right? Ask us for a consult for both addiction and sometimes also pain management expert, right? Such as Dr. Joanna Katzman, who's not here. Especially if they need interventions, or if there are a lot of medical and psychiatric comorbidities, the pain is very complex, then a pain expert can be of tremendous help with it. So I will stop here. There's some references.